Hello and welcome to AWCI's webinar, A Call to Action on Opioids and Naloxone in Workplaces and Worksites. My name is Tawan, AWCI's Education Program Manager. At this time, I'd like to introduce our presenters, starting with Beyer. Cal is Senior Director of SAFE Project for the national nonprofit SAFE Project. Cal empowers leaders to address root causes of addiction and amplifies the voices of those in recovery in workplaces. He is a 35-year safety and risk management professional dedicated to construction, and he catalyzed the mental health and suicide prevention movement in the U.S. construction industry. With him is Mike Hill, VP of Safety for Performance Contracting Group, Inc. Mike has been in construction and with PCG for 15 years, for which he has been on both the operations and safety side. Having been on the operational side of the company has afforded him the ability to relate to the field and operations and to know that safety and productivity go hand in hand. And last but certainly not least is Chris Sanders, VP of Safety at Valley Interior. Chris manages environmental health and safety challenges the company faces, as well as the risk and liability. He is also a retired combat veteran and a founding member and board member of TooToughToTalk.com, a mental health awareness nonprofit organization geared specifically for construction workers. It's a pleasure to have these gentlemen present for us today. In addition to today's presentation, they have also authored an article for Construction Dimension under the same title. You can scan the QR code on the screen right now and read more about it after the webinar. So with that, I'll send it off to you, Cal. Welcome, everyone.
Sal, thank you so much, and we appreciate you and Anne-Marie supporting us. Mike and Chris, thanks for joining me today. I'm excited to have you guys.
Thanks for the opportunity.
Yeah, absolutely. You're welcome. I wanted to just give myself a quick introduction. Even though I've presented previously at AWCI events and published many articles in the construction dimension, I do work for a national nonprofit called SAFE Project. It stands for Stop the Addiction Fatality Epidemic. I've worked in the insurance industry dedicated to construction since 1996, worked as a director of risk management and safety for a contractor in Washington State, and in that capacity, I helped launch the Mental Health and Suicide Prevention Initiative. But I've been especially keenly interested in the topic of opioid risk reduction and that intersection of substance use, mental health, suicide, and opioids. I'm thrilled to have Mike Hill and Chris Sanders with us today, two contractors that have taken a bold leadership stance talking about opioid risk reduction and opioid safety. And this is about emergency preparedness. At SAFE Project, we work not only with workplaces, but with veterans and caregivers. We work with communities, which includes treatment facilities, city, health, county departments that are helping individuals navigate pathways toward recovery, and on college campuses. We work along those 6 lines of operation toward the bottom, but we focus on substance use prevention, harm reduction, and recovery. So we'll get started. When Chris, Mike, and I did our article, we wanted to highlight hope in this epidemic that has taken over 100,000 lives many years in a row. We have had some promising news of reduction in total overdose deaths, but this is the time to double down, not let off the pedal. So we need to lean in and learn about new gateways for persistent opioid use. Our workers and their families are exposed in workers' compensation, and also we want to protect them from employer and union sponsored health benefit plans. We're going to talk about some of those leading gateways. We're also going to highlight how to talk to workers and their families about this idea of first dose prevention. We're going to talk about musculoskeletal injuries and how that does contribute to overprescribing, and our industry in many ways has been targeted because we haven't known how to talk back. And both Mike and Chris, you've done a great job asking questions and asking medical professionals to help you identify alternatives for workers and their families. The third key area is identify the what, how, and why of stocking Naloxone or Narcan in company workplaces and in work sites. And that's where we want to focus a lot of time and effort today. So the first polling question we're going to do is to ask everybody, have you stocked naloxone in workplaces and on work sites? Naloxone is a generic name. Narcan is a brand name. So when we ask naloxone, we also mean Narcan. So either or. And Tal will have you launch that poll. Chris, I know you're going to provide the findings of that poll.
All right, so yeah, we're gonna take a look and just kind of see where everybody's at on the call itself. So pretty quite a few people, 4 people saying they haven't done it. They don't know how or what to do. That's awesome. That's what the whole purpose of this seminar is about. We do have some people that do have it completed, so that's great too.
Awesome.
Looks like 1 under active consideration. So we're really looking forward to answering questions. If we don't help answer some of the questions that's on your mind, please let us know. All right, here we are. So yeah, three of you that voted say it's done. Thank you. We appreciate that. Big step putting Narcan or Naloxone or Narcan on your site. So that's a huge thing. Active consideration, you're where we all were, right? There's a couple questions out there that you probably got to answer before you make that leap. What I really find promising here is nobody is saying no. That's an awesome response right there. 0% that have no intention of doing it. And then, but there are some that are willing to learn why we haven't done it, but we want to know how to do so. So 50%. Pretty cool.
Sounds really promising. Thank you so much for doing that, Chris. So what we wanted to do is just let you know, as I mentioned earlier, last year, there was promising news. There was a 28% reduction nationally, and construction rivaled that reduction in overdose deaths. But one thing we've seen in the 3 decades of this opioid crisis, this changes quickly. And the cartels that are bringing substances in make formula changes, there's supply chain disruptions. A lot of factors go into impacting the availability of on the street drugs. And then there's a lot of people who are exposed from an addiction standpoint that they need to turn to the street if they're not able to continue getting prescription pain medication. So we want to educate people that this is a demographic issue that cuts across all major societal factors. Every family has potential to be exposed. We want to make this a safety topic. So the data that we follow has been the Construction Center for Research and Training. They are the CPWR. They do have a newsletter. I've listed the link for that newsletter and listed their recent data. But that newsletter is out quarterly, and it's called Resources and Effective Programs Addressing Suicides and Opioids Now. They call it Reason. It's a great place to track data. So we wanted you to know the reason naloxone is a necessity in workplaces. Over the last 12 years, the percent of occupational fatalities attributable to overdose of substances, including opioids, but also alcohol, has increased. It was 9.7% of occupational fatalities. So I monitored that over 12 years. The National Safety Council was also reporting that data. This made this really, in my mind, an emergency preparedness mandate. And companies like Valley Interior and Performance Contracting Group made that same call. And they decided to stock naloxone to be better safe than sorry. So we're grateful for that support, but we also wanted to just highlight quickly, opioids are a class of medication specifically for pain management. There are many categories beyond the 3 listed here of hydrocodone, oxycodone, or morphine. Generally, they are safe when they're used as prescribed by doctors. But because they cause euphoria and they can alleviate pain, it's very easy to accidentally overuse or misuse those prescriptions. So what we want to do is share with you what examples of opioids are. This was done by Johns Hopkins University, and SAFE Project gives attribution to that. Examples of opioids with the color coding. Any of those boxes with a red line are considered prescription pain relievers. Those that are yellow would be illicit opioids. And you'll see both heroin and fentanyl. You'll see fentanyl both red and yellow. It's used as an anesthetic. It's used for pain management, but it's also manufactured by cartels with illicit intentions. And the purple will be medications for treating opioid use disorder. So you'll see two main categories, methadone and then buprenorphine. I think it's important to just think about how important this is to understand so we can be aware, educate ourselves, educate our families. This is an area, as a risk manager, I had to get more involved with. Many years ago in the insurance industry, I saw some people who had injuries never really returned to work. I saw people with surgeries being delayed coming back to work, sometimes never coming back to work. And the more I dug in, the more I recognized we had to make this a safety topic, both in workers' compensation and employee benefits. So one factor I want to share is the leading gateway for new persistent opioid use would be on and off the job injuries. Musculoskeletal injuries in our industry run real high. Those are sprains, strains, ruptures, tears, repetitive motion disorder. So that's one category. We'll talk more about that. Also, I came to learn surgeries, medical procedures, and dental procedures that were being prescribed opioids were contributing to new cases of persistent opioid use. I followed medical literature. I partnered with medical providers. I learned from a lot of specialists that there were practical strategies we could do to teach people. And then the last category I wanted to mention is this idea of improper disposal of leftover pills. That word diversion means someone using those pills other than they were intended for. So here is a shocking data point. 90% of people don't properly dispose of leftover pills. We keep them for a rainy day in case we have a relapse of that injury and the pain. And on the one hand, I can understand how that makes sense. But on the other hand, anybody in our homes is subject to that risk. Unfortunately, many preteens, teenagers, young adults, even guests in our home have opportunity to divert those pills. And that can contribute to new opioid use. So the opportunity to educate ourselves and our families to be our best advocate for opioid risk reduction. There are alternatives to opioid pain management for almost every major type of procedure. So you can ask doctors, you can challenge and ask if there's an alternative. What we're seeing more of in the last 3 to 5 years are more people asking for alternatives, more people declining that opioid prescription because we recognize there is that potential for addiction and the potential for that diversion. So I wanted you to know those were 4 leading gateways that I wanted everyone to know. Now the data is pretty clear when it comes to the musculoskeletal injuries. There's a direct correlation. There have been many studies, NIOSH and the CDC. We know that to be the National Institute of Occupational Safety and Health and the Centers for Disease Control and Prevention. In 2020, they published a really timely article. We have a high frequency and high severity of those MSK injuries. That study called them work-related musculoskeletal disorders. So when you see that acronym WMSD, that's what that's referring to. First, we have an injury rate 77% higher than other industries. That study showed 34% of construction workers will have at least one of those MSK type injuries. Construction workers with those injuries were 3 times more likely to be prescribed opioids. So that was a succinct summary of a very thorough research study. There was another from the National Council on Compensation Insurance. So that is a group that monitors workers' compensation data, also from 2020. And of major industries, those of us in construction had a higher quantity of opioids prescribed for those injuries. It was 55% of the time. The next highest industry was manufacturing at about 27%. So we were double the average on that prescription rate. What was shocking to me is when I saw the data that construction workers received 20% stronger dose, and the duration of that prescription was 20% longer. So it started to help me understand and explain why I was seeing so many construction workers adversely impacted by the opioid crisis. I decided I needed to do something more. So even when I was a risk manager, I started talking to employees about these very topics. When I was doing some independent consulting, I also partnered with Safe Project and brought them in because I loved the work they were doing. And now I see contractors like PCG and Valley Interior helping drive this message. This is why. And there was another study done by the Washington University Medical School. It was a researcher named Dr. Anne Marie Dale and Brad Evanoff, Dr. Brad Evanoff. This pictogram does what a picture does. It gives you a depiction of a problem and then explains the details of what happens. Construction is hard work, manual labor, high rates of injury, people being prescribed opioids. One challenge that we still need to address in our industry is if people aren't working, we don't have a mechanism to always pay them. There are a few states that have paid time off, but that leads to people playing through the pain, sometimes aggravating an injury or exacerbating it, making it worse. And that leads to higher use of opioids. So also workers who are working when they're in pain can be impaired and not even know the risks. So it's really important to do what both Mike and Chris have done, is educate your employees about not working from heights, around energized equipment, not working in and around traffic and work zones where people can be injured. I know you're largely indoors, but we have a lot of activity on construction sites. And a lot of workers, when I do employee training, have never been explained some of those side effects. So this pictogram, this research study, 30 pages long, it's really worth a detailed read. Now, the last thing I want to highlight here is many things can contribute to an overdose. When contractors boldly embrace the need for naloxone on job sites, they're saying, we're prepared for all emergencies of any type. They're taking away the stigma. They're not being concerned about potential for liability. They recognize there's probably more liability in not being prepared. And if you think about the disruption on a job site, if an overdose occurs and no one has naloxone and no one has been trained, you can see where that would be a real big disruption and a distraction to the operations, to the morale on that job site. It's going to shut things down. The spillover effect is going to be huge. So what contractors like Mike and Chris have done is recognized overdose is real. The construction industry has had the highest rate of overdose among 19 major industry groups. Until recently, that was 131 per 100,000 workers died of an overdose. That compared to an overdose rate in construction, that compared to a suicide rate of 56 in the construction industry. So the good news is we did have a reduction last year. We can't count on that, so we need to be prepared. So some of the factors that can contribute to an overdose would be not understanding the directions, using a prescription pain medication prescribed for someone else. You might be of a different size, a different shape. You might have more tolerance. Someone might be prescribed a larger dose because they're a bigger person. They might have a different type of pain that might have multiple modalities of pain. But you could also be combining the opioid prescription with alcohol, not recognizing that would be double depressant and it could impact your breathing. Likewise, there are many over-the-counter products that can also suppress breathing or your heart rate that can contribute to a potential overdose. So I think it's really important to just recognize this is an opportunity for us to educate all workers on the symptoms of a possible opioid overdose. I've listed many of these categories. I love this slide that Safe Project did. It makes it simple. There is a reality though. Not all of these symptoms are indicative of only an overdose. There could be another underlying medical condition. So whether you dispense naloxone or not, or administer is probably the right word I wanted to use there, it's still important to make an emergency medical call to 911 to get emergency medical response on site. But non-responsive, slow to stopped breathing, people report that bluish gray color, specifically in the lips. Sometimes you'll see it in fingernails because you're not having adequate blood flow that's oxygenated. You'll have ashen or clammy skin. Sometimes people describe that as pale. Sometimes they'll describe it as gray. You may have a person who is limp, who's leaning over, who's not responsive. You may have vomiting from the effects of the opioids, and then weak or no pulse. In that case, administering naloxone and starting rescue breathing might become warranted. So take adequate precautions for universal precautions. So the last thing I wanted to do before I open this up and really talk to Mike and Chris in some applied case studies and hear from them about best practices, we thought it would be helpful for everyone to just have a quick overview about naloxone. It's been around for a long time. It's as old as I am. 1961, vintage. I told you it's a generic product name. It's naloxone hydrochloride. The Narcan brand is from Emergent Biosolutions. The real purpose of naloxone, we say, is to reverse the effects of an opioid overdose. So it's its sole purpose. It's what it was developed for, and it's what it continues to do. And it is very effective. It binds to opioid receptors in the brain, blocking the effects of opioids. Frequently, when the opioids are on those receptors, it blocks the brain's ability to breathe. So when naloxone takes over, it opens up that pathway to proper brain-body response for breathing. The game changer for me was March 29th, I believe, 2023. It became available as an over-the-counter medication. This made this so easy now to obtain. It became very accessible. It took away a lot of the barriers. Here's what's really important. It won't cause harm if it's administered to a person and they weren't having an overdose, whether that's an elderly or even an infant. So that's really positive news. Now, the last items that we wanted to highlight, if after administering naloxone, there's no response, you would administer a second dose. You'd wait 2 to 3 minutes after the first dose, but use the second nostril. Almost all naloxone today is done in a spray dispense. It's a plunger. You push the plunger and it immediately administers that dose. No need to prime that pump. It's very loose and it will go. It is a spray. So you use the second nostril if you have a second dose to administer in case there's a blockage in that first side. And I've already said this, but I want to reiterate. The effects of naloxone will last potentially 60 to 90 minutes, but we never know how much of a dose a person took. So it's important to call 911, get a proper emergency medical service evaluation, and then hopefully transport off site with that person alive, ready for treatment. That's positive. Now, the last item is we wanted to list. We're really proud of what our industry has done between joint labor management support to address the opioid crisis. We've listed a number of positive examples. If you have opportunities to bring naloxone into some of these other initiatives that your companies are involved with, please do take advantage. So Mike, this time, Tao's going to release the polling question. what obstacles keep you from stocking naloxone? And then we'll go through the responses, Mike, like Chris did on the first one.
Yeah, absolutely. Thanks, Kyle. All right, so you can see the question out there in front of you. What obstacles keep you from stocking naloxone or Narcan, as Cal said? Stigma about addiction, concerns about seeing mixed signals or substance use, lack of leadership support, policy, and or training resources, concerns about liability, and then the last possible answer there is don't know where to obtain naloxone. So we got about 21% coming in right now. We'll give it a few more minutes. Off the bat, it looks like, and this is a great question, don't know where to obtain it. And I think that that's a very valid point, especially in bulk. And that's something we dealt with as an organization, is how do you secure enough doses for sites and everything. So, all right, looks like about 25% of the people have voted. That by far is the highest. Concerns about liability, that's a valid one. And I think that there's a lot that Cal can offer there. And fortunately, Good Samaritan laws and everything, they apply to naloxone the same as AEDs and first response. So first aid response. Concerns about sending mixed signals on substance use, I understand that completely. And I think that we even had those questions on our team as we were going through the rollout process we'll talk about here in a little bit. So I think that's the results, Cal.
Thank you very much, Mike. And we do have an appendix that we may not have time to go through, but it will be attached to the PDF of the slide file. And in that appendix, there are various resources. There's a group called the Alliance for Naloxone Safety. We reference the National Safety Council. We reference SAFE Project. We have a Good Samaritan Law locator. There's many other resources that we put in place for people who were starting out. We also wanted to just say we didn't list every possible barrier. There may be others, and I'm sure in the Q&A, you may have some of those questions. So what I'd like to do is really move to why I asked Mike and Chris to be here, is to share some of those applied case studies. And so Mike, both you and Chris are really humble servant leaders that I've gotten to know a deep respect for. As I got to know you better, Mike, I just saw how bold you are. You are a clear communicator. And when you are making a decision, you look at things very strongly. And what I loved about your approach with naloxone, you viewed this as emergency preparedness and response. And you kind of made it feel like you're either prepared or you're not. There was no in between. So I loved how you just made that a proclamation. I saw how your team responded. I've used the analogy, you cut through the noise and you were decisive. And I just wanted to give you kudos for that. I wish more safety directors would be bold, and you and Chris have done that. So one other thing, Mike, I remember your team telling me that you said, I want to avoid confusion. So we're going to buy naloxone, Narcan, not generic naloxone, because I want this to be clear. Most people, when they heard about naloxone, were thinking about Narcan. Do you want to comment on that quickly, why that was such a key decision for you and how it helped you be clear?
Absolutely, Cal. I appreciate it. This was one of the big ones for us as an organization. I think that when you talk about the naloxone in the industry, it's not referred to necessarily as naloxone. And part of it, like you said, being that clear communication, direct, we wanted to make sure that people understood that, you are getting the actual product, you're getting a name brand product. And it's not necessarily the name, but it's brand recognition. And, when you look at it and you say, hey, we're going to put Narcan on every single job site across the nation. Billboards that are going up in different areas, they have the actual Narcan Emergent, as the manufacturer of Narcan. And it really was a clear direction from us to say, hey, there's no guesswork if this is naloxone, is Narcan, is it the same thing? And that's just the direction we wanted to go as an organization and just drive for that.
A lot of times, Mike, companies are worried about spending as little as possible. And you kind of cut through the noise and said it's more important for people to understand why we're doing this, what we're doing, and how we're doing it. And I just wanted to give you kudos for that. I thought that was really powerful in your implementation. Also wanted to ask you, how did you get leadership support? What barriers did you have to overcome?
Yeah, absolutely. Honestly, it was very enlightening. We started this conversation at a group we have called a safety advisory group. And it was just kind of a what if. And, what if we started doing this? Because we started seeing a few general contractors in some of our areas of, that we perform in, work in, starting to carry it. And it just started that conversation, just a general conversation. Our senior leaders, I have to give them all the credit, them and Scott McMillan on our team, because, they really took the ball and ran with it. The way that we work through that approach, when you look at it, it's much the same as mental health. People don't just leave the baggage at the door when they come to work. They may get into trouble on site just because the pain gets more. They have to be there because of the work, whatever. You don't know anybody's story. And I think that was a big thing, is really circling back to like our core values of, people first and being that type of organization, whether it's for our teams there that are on site, whether it is one of our employees, whether it's another employee from another trade, and ultimately just being part of care in the communities that we work around and we serve.
I think it's such a positive example, and thanks for giving that shout out to one of your teammates, Scott McMillan. He really embraced the challenge you presented to him to learn about Naloxone, to overcome each one of those barriers, and he was as diligent a student as I've ever seen, and he really made quick order of that, Mike. So I wanted to ask, any other thoughts you had on how you obtained that senior leadership support? Sounds like they supported what this safety advisory group developed.
Yeah, I think the big thing there was mainly just having a conversation about what it is, being real, and just the real talk around it. I think you talked about a little bit about quieting the noise, because I think that there can be a lot of those things. In that previous poll we talked about, there's places all over, where do we get it? How do we get it on site? What's it going to look like as an organization? What are we doing? And I think the big key here was just being decisive and going to leadership group with a proposal that, we're going to do our part as an organization, as people in the communities we serve, to put this on every single one of our job sites. I think the big thing, kind of the turning point for that was around, we didn't wait for a cardiac arrest event to put AEDs on jobs. And I think that that's a big thing when you look at like holistic safety, the total person and stuff like that. Naloxone is simply that next step in first aid readiness for us. And, is another thing, a minimal thing that we could offer to our teams out in the field and ultimately to everybody on site.
Yeah, and Mike, I think one other thing that I observed is you were realistic about the time frame. You were projecting that this would take anywhere from 4 to 6 months in a company your size and scale to be able to fully roll this out, and you waited to get that plan perfect before you did that, right? Or as close to perfect as you could. And that really felt like a positive lesson learned. So kudos there.
Thanks. Yeah, that was intentional. When we talk about best practices and kind of something that, for future sake, that was one of the instances where designing it out, that it wasn't going to be an overnight flip. We were going to have questions, concerns. We needed to have real talk and be direct about what it is and what it isn't. What our goal and intent, and explaining the why behind it was a big key. So why are we putting this on our job sites? Having that plan, and like I said, Scott, like you said, a student, man. When we first started this thing, I can't say everybody, including Scott and everybody on board, but it was like, this is the direction we're going. And I will tell you that he's the biggest proponent we have around this right now. Because of what he learned and how it has helped shape who we are as an organization, and ultimately what's out there in the field for us.
Yeah, thank you so much. Chris, I wanted to share, I've known you now since about 2020 when we met, and you were part of that group, Too Tough to Talk. And you, as a military veteran, had been close to mental health and suicide prevention. I asked if you would learn about overdose prevention as well, and you said, Cal, I'm not there. I not sure how I feel about this yet. And so I think what I'd like people to recognize, it's okay. You took the time to learn, and you went through a process where I saw your growth and leadership in this area go from resistant to reluctant to ready. And now the CEO at Safe Project, Jeff Horowitz, he and I call you relentless. You have just been such an advocate, and I want to thank you for always being open to share that process. Tell me a little bit about that process. And you saw that development as well happening. How do you feel now about this growth you experienced?
I feel great that we got to where we are as a company. I definitely was on the other end of the spectrum when we started, to be 100% honest. I had the same questions in the polls that you just took. What is the image? What is the liability? Should we be doing this? And I went through that myself. But the one thing we always have to do is challenge ourselves to understand what we don't understand. Cal was a huge educational component of this changing to help me understand the numbers, right? As in mental health, we know we're too tough to talk, 2 times more likely for suicide. The number's up now. And then when he threw that number of 10% occupational fatality to opioid, I think that was the light bulb that really went off on me personally. I need to take this more seriously and really understand it. So we dove in, we did some training, we learned what we need to learn, right? And then once I fully understood it, I felt like I was ready to answer the questions that our leadership would have.
And Chris, I know you went through a similar approval process, and the barriers were pretty typical of what Mike already explained. I thought one thing that you did really well is educate your team first. And then second, you decided in your organization, rather than pick one date, do everyone on a launch the same date. What would work best in your culture, your responsibilities, would be to go office by office, right? Almost like division by division. How did that work out for you?
I think that was the best way to do it for us. We let each market express their own concerns. In developing the plan to launch this, you can kind of see a picture on the right. To do this, we wanted every one of our markets to have input. We wanted this to be their program. Let them have a say in how it goes, what needs to be done. I mean, we discussed everything from what if a dose comes up missing to where exactly do we put this box on a green game box, our safety box. So, I mean, by allowing everybody to have their input, allowing everybody to voice their concerns and get legitimate, straightforward answers, it definitely made that conversation much easier.
And you both have large teams, and it was too much to tackle yourself.
Yeah.
So you both did delegation. You both worked to empower your teams to help you with this messaging. Would you call that a best practice or a lesson learned that worked in both of your cases? I'd like to hear from both of you, if it's okay.
I would say that's a necessity. This can't be a top-down driven program. It can be initiated, but our safety directors in each state, they took the lead of this, working with their leaders in the state. They were the ones that really drove the message and the conversation. All we did is kind of spark that, and gave them the data and the background to have the conversations. But I think you have to have a team to initiate a program like this.
Mike, anything more you'd like to add there to what Chris said?
Yeah, I would 100% agree with the team approach. I know for us, working through that stepped outline that Scott had came up with, over actually it was 4 months, where we trained, our regional safety team, and then they were prepared for the questions and the answers, to be able to provide that support to our teams. And then from there, training our operations leaders to understand what it was going to mean and what it was in for them, like as far as bringing them out to site and stocking them on the projects, to having foreman's trainings, to doing toolbox talks at the local field level. So we just had this multi-tiered approach. And so I 100% agree with what Chris it's not only a best practice, it's a necessity. You can't go at it alone.
Yeah, and I just love that. There's so many questions I want to ask you. So I'll jump in and we'll just kind of go rapid fire. One of those, I wondered if there were positive unintended consequences from rolling out naloxone, maybe that you saw ripple through your safety program. So those positive unintended consequences, do you have an example you'd like to share or highlight?
I had one situation where, and it was something we kind of talked about, but we didn't really explore fully. But when we launched this, one of the doses came up missing off of a job site, and somebody on the job site, needed it, and they took it. And at first, it was a problem, right? Everybody was looking at it as we're losing this. And then we just really turned things into do the right thing always, one of our values. And we said, hey, this is an opportunity. We now know that somebody on this job site needs some information. They need some help, right? We know that we can go to the GC now. And with that GC, we worked together. We brought this education to the site. We were able to talk to 800 folks about naloxone and opioids and mental health as well. So we turned something that could have been looked at as a negative, right? Yeah, we lost $40 dose. Okay, great. But for $40, we were able to help 800 people become more educated. So it was a great investment.
I loved when we pre-planned. I'm glad this topic came up. Mike, you use that term disappearing doses as well, and you viewed that as an opportunity, much like Chris. Anything you want to highlight there that was a good learning for you at PCG?
Yeah, I think it was very much similar. That's part of the open conversation when we rolled it out. That at least one dose will be, a 2-pack dose will be on site at all times, and that's been the biggest conversation. Is the world that we live in. It just doesn't, like I said, it doesn't leave or start at the job site. We got stuff at home, you got kids at home, you got all these worries in your life. And I think the bigger concern, I guess it's not a concern, is, hey, if a dose goes missing, I don't need to know. If it's administered on site, for sure, I do need to know about that so that we can get the appropriate steps and engagement there. But if it goes missing from site because someone's worried about their children at home or their college age student or whatever it may be, or they want one for their house, I think that's all part of that education series, just making sure that everybody understands that this is here. And I'll tell you, it's very refreshing to see community centers are now carrying them in like old newspaper bins. I know some people may be too young to understand what those were, but where you got the newspaper from the quarter machine. But I've seen that. I've seen it at Costco. The Costco pharmacy even has it. But there are ways to get it. And I think the biggest thing for us as an employer is just not to be like, if it goes missing, it's not that it got destroyed or thrown away. It went missing because someone needed it.
Yeah, I thought that was a really positive attitude both of you reflected. So thank you for that. Next question real quickly is, what type of reaction have you received either from owners or general contractors, maybe even subcontractors you're doing work with? Have you seen a ripple effect? Have you seen others following suit?
I think for us, we were seeing some on some general contractor sites, so it's a kind of a support of solidarity when you're coming alongside, and like not only are they carrying it, but we're carrying it. So there's multiple doses on the job site. I think that the kind of evolution of that, especially for us, is to find those champions, right? To find the people that want to carry it not because it's a company policy to have it on every site, but just being that onus of, hey, you know what? I'm ready in the event that something could occur.
Yeah, that's powerful. Chris, how about you?
I would probably use the word curiosity. A lot of our GCs, some were on board, some weren't. Some were like, hey, why are you doing this? It sparked a ton of conversation, which was really positive, right? And I would say after we launched this, like more and more GCs now are coming around to the idea that, hey, this does, Mike says it's the best, right? It's, you don't plan on a heart attack, but you still put the AED up there, right? You don't plan on a fire, but you got the fire extinguisher, right? So we know the data. We're not planning on having a situation where somebody's in a peril, but we need to be ready just in case. And I think that's the biggest thing. We sparked that curiosity, that conversation, and more people are coming around to putting these on the site.
This is too good to stop. So I'm going to just think about a couple other comments that you both shared with me. Chris, one that you talked about, we call them conversions of attitudes, that not every leader, supervisor, or employee was bought into, why are we doing this? And yet, after you did the education, after you did the rollout, you saw what happened when people were educated. So do you want to share quickly what that feels
Sure.
like as a safety professional when you see that type of change?
I mean, the concerns that they had, I had myself. So it was honestly very easy to understand where they were coming from. I had already worked through that in my own personal space that I needed to figure out for myself where I was at. So when a lot of these questions came, it was true empathy for what they were, considering or where they're coming from. I thought the same thing, but here's what I did to overcome that thought process, that stigma. And a lot of those conversations kind of melted away on their own. And then they really come down to the bottom line is you want to do the right thing always. That's what everybody wants to do. That's what every safety professional's out here to do. Everybody in the trade's out here to do that, right? So it was really like, why wouldn't we do this? That would usually be the last question. Like, is there enough negatives that you can't overcome the one positive of saving a life? Nobody is gonna go against that question. So it was really just letting people come to terms on their own time schedule, in their own accord, instead of trying to force it to them.
Yeah, thank you so much. Like, powerful change initiative, and the way you communicated was so clear. Mike, you have been working with colleagues internally, and you shared some conversations, even with your insurance broker, looking at ways to co-dispense for work comp injuries and possibly even in employee benefit plans. What kind of update can you give us about the progress being made there? And I thought that was a really positive conversation. I wanted to thank you for that.
Yeah, Cal, the thing I kind of spurred me was, if this is something that obviously it's not just isolated to an industry or anything else. And so it got me asking the question, what else? And so I reached out to our comp team to really try and understand, is there something that our insurance broker can do around co-dispensing? And, every time it happens, unfortunately, we did have a significant incident, and, the individual was prescribed a narcotic as well at the same time he was co-dispensed. And that really got me thinking, like, okay, can this be? We ran into a little bit of a hiccup, like there can be recommendations around this, but ultimately that decision has to come from the doctor. So those conversations are having to happen earlier in that injury process, whenever it's, a comp injury. And then it kind of came on board a little bit further, and it was like, what about an employee benefits program? There's a lot of talk around that. And the one thing you can control is, the employee benefits that you provide your teams. And that's been a bigger conversation, probably a little bit more traction on that front. I wish it was a lot easier just to say, hey, anytime a opioid is prescribed, that, we're co-dispensing this thing, like Chris said, whatever the cost may be. I think it just hits home for me as, a father and having kids and stuff. And, you
Yes.
don't know, like you said, people hold on to these prescriptions for the rainy day, or the what if my tooth starts hurting or my back starts aching again. And you just never know where it could, raise its head around the house, or, in a different atmosphere. And so I wish those were a little bit more promising conversations, but what it has done is, kind of looked at the process of a claim, and where does that start, and where does the prescription get issued, and can we have that effect on that end result? So
It's an area that I spend a lot of time on, and like you, I feel we're making progress, but we're not quite there, finding easy solutions. So thank you for sharing that. I think the more people that have those conversations, the more likely we are to get the medical community to respond. So guys, boy, I have so many more questions I'd want to ask you, but we also talked about if we haven't convinced people at this point that this is the right thing to do for the right reason, and it's a relatively low cost initiative when you think about the high ROI, we wanted you to know a study that was released in the Journal of the American Medical Association, a leading medical journal, looked at 840,000 patients, so 840,000 households, and it looked at the opioid risk with one prescription in a home of an overdose. With one opioid prescription, there was a 60% increase of an overdose in that household. When two prescriptions or more occurred, it went to 625% increase. This to me was like a mic drop moment, and this should have gotten way more attention. So we wanted you to know anytime a family member needs to be prescribed an opioid, a doctor feels it's essential, ask if an alternative exists, ask if you can be co-dispensed naloxone, but also be aware with those leftover pills, there are many commercially available products for at-home disposal that will deactivate the chemical and then allow for safe disposal. So these are things you could reach out to me at Safe Project. I can share articles I've written, information that we've shared, help you identify some of those strategies. In the interest of time, I'm going to go quickly. Mike, Chris, and I spent some time talking. We want you to recognize that there is a reality. Your organization has likely faced risk from opioids. The National Safety Council back in 2020 said 70% of organizations. It's probably higher if that was redone. Number two, it's not that there's not liability. It's important to recognize there are Good Samaritan statutes. I loved what Mike said about the same application to first aid, AEDs, CPR. But do look at those Good Samaritan statutes. In the appendix, we put a locator to where you can find the Good Samaritan statute. Number three, it's important to get that leadership support and to do what Mike and Chris have done, explain how this will enhance emergency preparedness and response. Both companies, PCG and Valley, educated managers, field supervisors, and safety about the signs and symptoms. They actually have educated employees as well and how to administer naloxone. And then both companies took a evaluation of how much naloxone to stock. Most organizations who make this decision are using a judgment of 3 to 4 minute maximum time to be able to respond to a person who might be low breathing to stopped breathing. So they're using that as a judgment to where do we need it and how many doses should we have. Lastly, there are a lot of logistical considerations. Sometimes this becomes noise and bogs people down in the decision, but where are we going to store it? Who's going to have responsibility? How are we going to monitor and replenish? That goes with storage options as well, temperature extremes. There's a lot that we can talk about. Lastly, provide employee training for everyone about opioid risks and safety factors. You heard Mike Hill talk about toolbox talks, and you've heard both Chris and Mike talk about other steps they took. So Tao, we're going to pass this back to you for Q&A. And then what I'll do is scroll through our contact info and go through the appendix so people can at least see what's in there. But Tao, I'll turn it back over to you. Mike and Chris, thanks so much for your great participation today.
Yes, thank you, Cal and Chris and Mike, for that informative presentation and for your heartfelt conversation about this topic. We appreciate it. So a couple of questions here. Is it sufficient to train only safety staff or only safety and supervisors on naloxone, or is it important to train all of your workers?
Mike, Chris, do you want to take a crack at that?
Yeah, I mean, we started with our safety and superintendents, rolled it out to them, then we rolled it out to the foreman, And then when we actually took the naloxone out to the site and mounted it to the box, we did a site stand down with all of our crew on that site, educated them how to use it, what the signs and symptoms. I think the best practice is going to be you want to educate all levels. Without that full understanding from top to bottom and those different layers of viewpoints of what it means to them, obviously your field, you're talking in a little bit different viewpoint than your safety team. Still same goal, but different kind of conversation. But I think all levels is the answer.
Mike, anything you'd want to add?
I would 100% agree. I think that from an administration standpoint, it's the same thing with training people on first aid. They can choose to use it or choose to not to use it. The training's so simple. The biggest thing is recognizing the hazards like associated with it, what it does and what it doesn't do, and then the administration process of it. So, should something occur, how comfortable are they in that administration of it?
Yeah, great responses. Tao, if there's another question, we've got experts here to answer them.
Yeah, so when talking about naloxone, people usually think about that hands-on administering to use in emergency. What should we do, or how do we get people to buy into learning about the root cause of the situation?
Does someone want to take first crack?
Yeah, I mean, it's a very sensitive topic, but I think you got to tie this into mental health, right? Different reasons to be in the situation where naloxone may be required. There's a ton of different reasons, right? It could be availability, not understanding opioids, addiction. There's some things that you can help. So I think the answer to that is how we got there. Does it matter at that point? If we're in a crisis, it doesn't matter. Let's treat it and let's let professionals help them figure out where and how they got there. I think that's your aftercare. So
I would agree. I think this is very similar. If you attribute it to like a heart attack, right? I don't really care how they got to their heart condition. It's more, did we save the individual? And I think that that's an important piece, and it's tough as a safety professional to wrestle with, like, oh, what's an RCA and how do we stop and help this? Is it systemic to our job site? Is it, a region of our country? Is it, I don't know. Those questions are as important to me. I think it's good to have the administration, the saving moment, and then have something to turn to, like an EAP, that they can handle some of the stuff that they may be going through.
Yeah, you guys did a great job with that question. I appreciate that response. The EAP, treatment, recovery, Chris, you used the word aftercare. That would make that a holistic approach, and you guys nailed that one as well. Thank you.
Next one, New York just passed legislation to require opioid overdose prevention on work sites. Do you see other states following?
Only hope.
Yeah, it's been a slow movement. There are a few areas. The province of Ontario in Canada did issue a regulation that required the availability of naloxone on site. And the state of California did pass legislation that will require it in the future. I believe it starts 2027. And if anyone has a specific need to know the actual date, let me know and I'll be happy to send you additional information. That's been something that we've monitored. We're starting to see a few states. Washington State recently passed legislation for mental health training in construction and other apprenticeship programs. So it's not going to surprise me if naloxone moves in that direction. There may be a few other workplace initiatives, but not as broad as the one in New York or California thus far.
Great. And last question here. There's been an incident where a patient had symptoms of an overdose, but they tested negative for opioids, and it turned out like the drug was a custom cocktail. Is there a way to address this, or how should this be addressed in that safety industry?
So I'll jump in on this one, Mike and Chris. I get asked similar questions. What is very challenging about street drugs, or if people mix multiple substances, the naloxone will work on opioids. Today, there are, quote, cocktails that are being mixed of various chemicals that include not only something like fentanyl, but also animal tranquilizers. And the more of that animal tranquilizer exists in that compound, the less effective the Narcan may be, and you may need to administer a second dose. So having naloxone be available, contacting 911 for emergency medical services is crucial. Anybody that we care and love, make sure they don't use alone. There are opportunities to help provide guidance to individuals about safe methods or harm reduction. It would include testing for fentanyl and other substances. And there would be many more opportunities to share additional information. Safe Project's website does have additional information on that category. So if the person who asked that question would like additional guidance, you can reach out to me confidentially, or you can scroll our website and find additional information how to help individuals that might be subject to that exposure.
All right,
One,
thank you.
one more point on that. Just remember, naloxone is a safe alternative. It works on opioids, but it will not hurt you. So
Yes.
there's very little downfall of trying something that might help. It may or may not help, but not using it will not help at all, right? So just keep that in mind. It's a very safe drug. You could take it if you were not in an opioid crisis. It will not affect you. It will not hurt you.
Yeah, great
Might give you a
reminder.
headache. Be about it.
Well, that wraps up our Q&A session. On behalf of AWCI, we would like to thank our presenters. Thank you so much, Cal, Mike, and Chris. Thank you to all the attendees for joining us today. We'll see you next time. Bye now.
Thank you, everyone.
Thank you, everyone.